attention this systemic fibrosis that is permanent and becoming more and more prevalent, because before we've been using gadolinium right and left, very high loads, multiple tests, and now we are basically harvesting the consequences. Also, it's expensive, not available in every single hospital, every single clinic, especially newest scanners that provide very high resolution. It again cannot detect lower extremity valvular insufficiency, or very limited application for that diagnosis, and still suboptimal resolution in below the knee veins, even for the most sophisticated scanners. Again, this is the list of contraindication: absolute cardiac pacemaker, removed with the wires, aneurysm clipped in the brain, etc., etc. Patients having claustrophobia, inability to stay for a long time in the horizontal plane. Sometimes they don't fit in the MR scanner because of the large size. And I'm just going to tell you a little bit what I learned from MRV evolution. Initial reports of using MR for vein assessment was since 1986, Erdmann and his group in radiology. It was related to development of 2D time of flight protocol. Radiologists were experimenting with different flip angles, pulse sequences, compared MRV to contrast venography. They found the suprapopliteal vessels were seen by MRV best. This is the group of Japanese scientists that had the most sophisticated scanners in the 80s. In 1997, Nagayoshi et al. Also added tourniquet and warmed the feet to better see calf veins. They really tried hard to see the veins below the knee, but those were in healthy volunteers. They said, yeah, it's seen a little bit better, still not really good. 1998, they added low-dose gadolinium, tourniquet, and 3D FISP sequence. And again, there are a lot of abbreviations, a lot of really fancy names for different types of protocols. It's a 3D fast imaging with steady-state precession. Sharper images, more veins seen, still not good below the knee. 1997, big paper in JVS. It's called Bullseye Sign and Serial MRIs with gadolinium determines thrombus presence and age, because before there were also these debates, acute versus chronic. They're saying ultrasound is not good, venogram only shows the lumen. But just imagine, scans were done at diagnosis 3, 5, 7, 14, and 90 days after. At that time, they did not know about systemic sclerosis that was caused by gadolinium. So, but thank God there were not that many patients that were enrolled in the study, and not many actually had that many scans. And at the time also probably the cost was not the issue that it is now. 1998, Moody Radiology, magnetization prepared 3D blood and fat suppressed MR imaging sequence in patients with proven DVT. Again, they tried to estimate age of thrombus without contrast. 2001, they're still trying to detect infrapopliteal DVT with MRI, compare it with duplex ultrasound and contrast venography. Just disclosure of the study, they had almost 600 suspected DVTs, and they only, after all exclusion criteria, all contraindications, everything else, they found 73 patients, but were only able to complete 14 studies and found that duplex was as good as the MR, venogram wasn't as good. Again, the duplex was the best. 2001, another 3D FBI, fresh blood imaging protocol with DVT. Still hard to differentiate veins from arteries. Challenges and challenging. In 2002, they tried to visualize thrombi, not just the filling defects. It's called MR direct thrombi imaging, MRDTI. So then they became even more complicated. 4D track, time result angiography using keyhole technique, obtained images during multiple vascular phases, arterial, venous, and venous, and detected early retrograde Arrhenian vein filling in multiple dilated privileged varices for pelvic congestion syndrome diagnosis. There'll be the whole session in the afternoon, but this was actually one of the very rare studies that showed the MR was able to detect reflux. Very limited application. In 2011, MRV before and after long stretch bandages wrapping in attempt to detect venous insufficiency. They found a little bit decreased superficial flow and a little bit increased deep flow. It was done in China. I guarantee you there is no probably MR machine in the US and Brazil that could be used in that way, where you could wrap, unwrap patient's leg and do these repeated studies. In 2011, MR phlebography with blood pool contrast agent glucophosphate, which is a relatively new, only need very limited amount of this contrast, and 3D gradient echo sequence, which is very quick, 9-minute total time, allows accurate detection of DVT. That's probably as sophisticated as it can go. So MR, MSC, TV basically have the same imaging territories. SVC upper extremities, portal, mesenteric, renal, IVC, pelvis, and lower extremity. I just want to show brief examples. SVC and upper extremity MRV. SVC syndrome, such in this example, is a large mediastinal mass that is compressing the SVC. You can even see plethoric features of this man. upper extremity vein stenosis and compression, catheters, ports, planning, and evaluation. This is very useful for patients with hemodialysis, with TESIOs, with fistulas, with multiple upper extremity veins, ports, and catheters. Thoracic outlet syndrome, a very good correlation between the MRV and the angiogram. Visceral venous MR, again, very good correlation between the angiograms and MRV. To detect portal hypertension for retroperitoneal varices, TIPS workup, Budd-Chiari syndrome. In transplantation, to assess collaterals and how to approach and what's the best way to transplant the liver and other inner organs, renal vein compression, and IVC imaging. There are a lot of clinical indications to assess the patency or agenesis, occlusion, thrombosis partial and total, like in this case, completely occluded IVC and dilated the esophagus system, compression of the IVC, and various anomalies. Here are just the examples. This is the retroperitoneal node that is occluding the left iliac vein, compressing the IVC. This is a large mass that is not seen basically on the anterior posterior view, but well seen on the lateral view. That is a sarcoma compressing the proximal IVC. IVC tumor invasion is very well assessed with MR. Again, there will be another session and talk by Dr. Van Risto on this topic. Invasion of the tumor in the IVC, really well depicted by the MR that shows not only the vein but its surrounding tissues. This is the IVC tumor, leiomyoma. Actually, their investigators from China suggested that contrast-enhanced MRV is the first choice perioperative image of leiomyosarcoma. It gives really great definition. Various IVC anomalies such as circumaortic left renal vein, retroaortic left renal vein, duplicate IVC, left and right. Pelvic congestion syndrome, classic history, gravity-related symptoms, pelvic pain, worse with exercise and prolonged standing, worse with menses, better in the morning, worse in the end of the day, relieved when the patient lies supine, more often on the left. A classic diagnostic with ultrasound, and here just the MR, normal, dilated ovarian veins. MR for lower extremities shows us the compression or dilation. Here is the dilated popliteal vein that is seen on the angiogram and very well correlated with MR, panoramic images on the ultrasound, the same in transverse. Again, very well depicted the DVT. This is one of the older images that shows not only the defect of the filling, but also multiple areas of the non-occlusive thrombosis. Complications, just remember just 10 years ago, family of boy killed in MRI accident sued for 20 million when there was an oxygen tank that flew during MRI exam and killed the patient. It's rare, it happens, but it's still very dramatic. So, and a little bit of outline of the CT venogram evolution, which is, as I mentioned, is basically the same indications, the same picture that we could see, but it started using for venous application with spiral CT technology. It was better image of iliac veins and IVC extension, but using 80% less contrast. They found it in 1996. It helped identify underlying pathology in extensive DVT, vein compression by arteries, bony spurs, venous structures. Latest trends are towards minimizing radiation exposure. And they found that the 64 detector indirect CTV could decrease amount of radiation by almost 30%. Very fancy pictures. Applications are basically for AV malformation, like in this case. 3D reconstruction gives really great depiction of every single venous collateral and varicosity in these patients, involvement of the joint, like in this area, in this patient. Varicose veins, detailed anatomy, complete picture, different fancy reconstructions, anatomy of the small saphenous vein insertion. They say knowing that before excision helps you prevent varicose veins recurrency. Very interesting, CTV diagnosis of atypical reflux. The group of scientists in Korea found that isolated venous reflux from pelvis and volar perineal region can cause lower extremity varicose vein even without pelvic congestion syndrome. They found 15 females, 20 limbs. 73 of them had no history of chronic pelvic pain, and they found that there was a reflux in the posterior veins. They found dilated ovarian vein, confirmed with the angio, embolized, and got rid of the varicosities. And so what comparison of CTV and MRV? Basically, CTV misses web spurs, trabeculations in the vein, and MRV picks them up very well. Vein walls thickening, again, is better seen on MRV. But with CT instant, intimal hyperplasia can be seen. So MRV is preferred over CTV to minimize exposure to radiation contrast-associated risk. It's the group of Netherlands in phlebology. And another thing we could use in our Overdale practice, the LOVE score. A novel scoring system, again, for the same group of Arnoldson from Netherlands. They found 9 areas of the venous system in patients with chronic venous insufficiency or DVT symptoms. They did MR. They found, for example, trabeculations in this common femoral vein. There was evidence of May-Turner syndrome in the duplex. And they have this table where they found all the symptoms, 0, 1, 2, 3, all of them, and they score this based on the presence of DVT, compression, trabeculations, and every venous pathology, and then they treat the patient based on combined findings of very high quality duplex ultrasound and MRV. So that's the contemporary approach. In conclusion, CT and MRV offer a wide range of protocols and algorithms to assess deep venous system and surrounding tissues. They provide most imaging advantages for venous anatomy above the popliteal vein, still after all the advantages and all fancy protocols and best resolution scanners. And just of note, CEP, EAP class 5 and 6 patients may benefit from routine suprainguinal CTV MRV due to high incidence of obstructions. It was found that more than 50% stenosis is in 37% of patients with severe venous insufficiency, and 23% have more than 80% stenosis. So routine ordering of CTV and MRV will help them direct the therapy, for example, iliac vein stenting for these patients. Thank you.
Obrigado, Natalie.